focus on the effect of posterior capsulotomy size on refraction, IOP, and macular thickness. So, we all know that posterior capsular opacification is one of the most common complications of cataract surgery, which causes secondary visual loss, glare, and diplopia. It can be treated by Nd:YAG laser capsulotomy, but complications of the procedure include IOL dislocation, cystoid macular edema, increased IOP, pitting, etc. The optimal size determined by the surgeon is based on many factors, which depend upon scotopic pupil size and size of IOL. So the aim of the study is to see the influence of size of capsulotomy on spherical equivalent, IOP, and macular thickness. Coming to the material and methods, it's a prospective study. We included pseudophakic eyes with uncomplicated cataract surgery with PCIOL implantation and BCVA less than 6/9 who were treated by Nd:YAG laser posterior capsulotomy, and sample size was 50, and we excluded patients diagnosed with glaucoma, steroid responders, corneal opacities, uveitis, retinal diseases, etc. So methods, we took a detailed history and examination, and follow-up was done at 1 week, 4 weeks, and 12 weeks. So deciding capsulotomy size. It was decided by the surgeon based on the fact that it should be similar or larger than pupil's diameter in the scotopic environment. And it was measured with the help of reticule of slit lamp before the dilatation of pupil. We performed YAG cap after putting a drop of tropicum at 1%, and we applied topical proparacaine drops, and laser shots were delivered at the level of posterior capsule. After doing the capsulotomy, post-op drops were prescribed like bremonidine and lotiprid. Patients were basically divided into two groups. Group 1 consists of 24 patients with capsulotomy size less than 4.5, and Group 2 consists of 26 patients with capsulotomy size greater than 4.5. And after that, the changes due to laser capsulotomy in spherical equivalent, BCVA, IOP, and central macular thickness were studied. So we'll come directly to results. Group 1, that is less than 4.5 millimeter, it included 48% of the participants, and Group 2 included 52% of the participants. Mean age, it was 62.84 plus or minus 10.46. 40% were females and 60% were males. So it was found that in both the groups, mean IOP, it increased in the first week of follow-up, but at 1 month and 3 month follow-up, the mean IOP decreased in both the groups. Similarly, macular thickness also, in the first week, there was an increase in both the groups. But in 1 month and 3 month follow-up, it decreased. And it was found that IOP increase and macular thickness increase was more in Group 2 than in Group 1. We also compared power, shots, and total energy. Only difference among the two groups was that in Group 2, the number of shots required was more, obviously, because the size of the capsulotomy is greater than 4.5, which required more shots. Spherical equivalent, it was found that there was a hyperopic shift in Group 1 and there was a myopic shift in Group 2. So coming directly to the discussion, there was a statistically significant and stable improvement in BCVA after YAG cap in two groups over the whole period of follow-up. And also in Group 1, we saw there is a hyperopic shift, and Group 2, there is a myopic shift. And the increase of mean IOP and mean macular thickness, it increased at the first week and decreased subsequently, and both the increase was more in Group 2 than in Group 1. So these are my references. So thus concluding that laser capsulotomy is the gold standard treatment for PCO because it can be done in a polyclinic condition and improves the visual outcome. Our treatment strategy and recommendation is that the opening should be larger than the size of pupil in scotopic conditions. Thank you.
Thank you for
Thank you.
Kindly.
Hello. Just one query, why there is a shift of different type of shift in both the capsulotomy?
So basically, we did this study so that whether to know whether a small size or big size is appropriate. But doing this study, we can't predict in all patients. It depends upon the scotopic pupil size, obviously. And also, like asking me personally, it will be better. In many cases, we found that if we are putting a capsulotomy size so small like 3 mm and all, the patients end up in the subsequent follow-ups, tags, capsulotomy tags will be there, and BCVA is not improving. So asking me personally, it will be better if we put a slight bigger capsulotomy, because IOP increase, macular thickness increase is there in first week, more in group 2, but in the subsequent follow-ups we can see that it is becoming
But
correct.
his question was the myopic and hyperopic shifts.
Okay,
Yeah.
okay. Oh, what was it?
I'm giving you the clue how it happens. It might happen. It is
Sir, hyperopic shift happens because of tilt of IOL posteriorly.
Now that's I'm telling you. If you could have measured the anterior chamber depth from the anterior lens surface to the cornea before and after, with the bigger size, there is more vitreous thrust and pushes.
Yes, sir.
This could be the clue. Exactly, ELP. That is the question he asked, and I've given you the answer.
Oh, okay.
So you can study that one, anterior chamber depth. In
In the
both
subsequent
groups.
studies, we will have to include.
Not in the beginning, but when it stabilizes.
Okay, sir.
Then, yeah, thank you. You are the only author, right?
Yes, sir.
Fine.
But the author and co-author same name. Bindyasi. I don't know whether C is different. Author and presenting author.
Actually, a presenting author was my guide, but she was not able to attend the conference.
His name was in the.
I have put in
Is
this.
nothing
No, here only your name is there as author. Again, as co-author, it is Dr. Bindya.
She was presenting author only.
there. All right, no problem.
Done.
You could have given her name
And-
or his name as a co-author.
Oh,
You are
yeah.
too. That's it is not to criticize you.
Okay.
It is nothing to criticize you, to encourage you. Put your guide name in there as a co-author, no problem.
Yes, sir. Okay. Thank you, sir.
Okay.